Hi, my name is Anna Ibele. I'm an associate professor of surgery at the University of Utah, and I'd like to thank SAGES for the opportunity to present today. I have nothing to disclose. I'd like to thank my colleague, Dr. Andrew Gowron, for help in procuring the manometry images for this talk. When you're lost, particularly in foregut and bariatric surgery, sometimes it's important to go back to the beginning. And dysmotility of the esophagus, dysphagia after bariatric and foregut surgery is a great example of this. Manometry is useful in these patients to evaluate for esophageal dysmotility prior to reoperative fundoplication in the setting of late recurrence of symptoms, and also for early postoperative dysphagia after fundoplication. Sometimes manometry can be very useful in these patients. Occasionally, it can also be useful in dysphagia following bariatric surgery, and I've been asked to speak about these three instances today. So dysphagia post-bariatric surgery is generally due to a variety of factors. Esophageal dysmotility is usually not one of these. So far more common etiologies of dysphagia are dietary indiscretions. The patient is eating something too tough or not separating their solids and liquids. Anatomic problems can also play a role, and these are usually best characterized endoscopically. So anastomotic strictures, narrowing of a sleeve, ulceration of an anastomosis, torsion or spiraling of staple lines. And then on cross-sectional imaging or esophagram, one might see a stricture or a hiatal hernia. Manometry can sometimes be helpful, though, in the evaluation of a complicated patient. And so to illustrate this, I was going to present a patient of mine who was somebody I was taking care of kind of in my first year of practice. So this is a patient with a BMI of 49 and multiple weight-related medical problems. In addition, she had rheumatoid arthritis and Sjogren's syndrome, and she underwent a sleeve gastrectomy with repair of a small type 1 hiatal hernia. Post-operatively, looking back at my op note, I dictated that she had an appropriately patent chorioplasty, appropriately configured sleeve without evidence of leak or staple line bleeding or angulation deformity on completion of her endoscopy. And at 3 months post-op, she came in for her routine follow-up and reported some mild dysphagia with solids if she was eating too quickly. And I coached her on dietary modification. And then at 6 months, she came in to follow up with the PA and reported that she was having some problems with fruits and vegetables causing gurgling in her throat. This was kind of infrequent, no greater than maybe once a week, and didn't sound too worrisome. But then at 7 months, she called the office with pretty significant solids dysphagia, early postprandial nausea, and vomiting of undigested food. She got some dietary coaching and backed down on her diet and then re-advanced. And I saw her in clinic 2 weeks later with persistent symptoms. So the differential at this time, well, it could be dietary indiscretion, although that would be a little bit unusual for new onset symptoms at 7 months. Maybe she's got some clearance issues due to Sjogren's. She has dry mouth, dry esophagus. It could be reflux. Maybe her hiatal or paraesophageal hernia has recurred. She could have ulcers, even though it's a sleeve. She's on a lot of NSAIDs for her rheumatoid arthritis. Maybe this is some late presentation of a stricture at her incisura, or I left some fundus behind and this dilated up. So to better evaluate this, I got an endoscopy. And endoscopically, what I see here is that she's got a little recurrent hiatal hernia. So I measured that at about 2 centimeters. But the scope really seems to shoot straight down from the esophagus into the sleeve. I didn't find it to appear torsed or narrowed, and it looks wide open there at the incisura. So I'm not really sure what the source of her problem is. So I got an upper GI, and you can see on the upper GI x-ray there, there's a recurrent hiatal hernia. The radiologist also commented that the tablets she swallowed hung up in the mid-esophagus for a couple of minutes before moving on down. And then also queries whether or not the sleeve is narrowed there as it traverses the hiatus, which is not something I had appreciated endoscopically. So the differential there, thinking about what to do for this patient, it's now about 8 months out. Her symptoms are pretty persistent and she's pretty miserable. She's trialed PPIs and Carafate. It doesn't seem to be helping. A couple more weeks pass and she's wondering, well, what can we do? And so, the questions I asked myself, is this narrowing that the radiologist felt like they saw on her sleeve intrinsic or extrinsic? I can appreciate it myself on the upper GI, but I don't really appreciate it endoscopically. Did I create a problem with her sleeve? Does she need to convert to a bypass for some intrinsic stenosis? Or should I just repair her hiatal hernia, which would be nice. She could keep taking her NSAIDs. Also, is esophageal dysmotility playing a role? She has rheumatoid arthritis, she has Sjogren's syndrome, maybe she's developing some other rheumatologic problem with resulting in clearance issues with her esophagus. So to better sort this out, we got manometry, and demonstrated here, she's got about a 1 centimeter manometric measure of her hiatal hernia. Her IRP is a little bit elevated at 17.4, and her DCI is 2278. She's got intact peristalsis. And so our GI doc took a look at this as well and very astutely said, well, she's got EGJ outflow obstruction. And so on her x-ray there, she's got this proximal narrowing in the sleeve. Maybe this is the area of obstruction. So putting this all together, endoscopically, she doesn't seem to have intrinsic stenosis. Radiographically, she has a recurrence, and there's a little bit of angulation of the sleeve there, compression by the diaphragm. Manometrically, it doesn't look like she has an intrinsic peristaltic abnormality of her esophagus, but she does have EGJ outflow obstruction right at the level of the hernia there. So after some discussion with her, she elected to undergo repair of her hiatal hernia. We did not convert her to a bypass, and her dysphagia completely resolved. I since learned over the following several years, both from my own patients and from patients referred in, that dysphagia is not an uncommon presenting symptom, even with a small hiatal hernia recurrence in a sleeve patient due to EGJ outflow obstruction from even minor kinking of the sleeve from that recurrence. So on to more complicated topics. Evaluation of dysphagia post-fundoplication. When I think about this, I break it down into kind of late post-op dysphagia and early post-operative dysphagia. Late post-operative dysphagia, unfortunately, is most frequently a symptom of a recurrent hiatal or paraesophageal hernia. But it's also important to evaluate patients for intrinsic esophageal pathology, esophagitis, strictures, malignancy. New onset motility disorders are pretty rare. Early postoperatively, it's a little bit more complicated. 99 times out of 100, it's edema at the cruroplasty and the esophagus and the wrap, and it will resolve. Sometimes dietary behavior can play a role. I'll never forget my patient that ate 3 slices of pizza a week out from his Nissen and then called the office because that was problematic. Anatomic problems can also be factors though. So it's important to have early post-op recurrence in your differential, misconstruction of the wrap, problems with the cruroplasty. In late reoperative dysphagia, I think manometry is very useful in evaluating patients with or without dysphagia. And really, I feel it's pretty essential prior to reoperative fundoplication. It's nice to compare to the patient's initial motility if that was done. And it's important to establish their current baseline, rule out major dysmotility disorders, pseudoachalasia, assess for ineffective motility. Early post-fundoplication manometry sometimes plays a role in the evaluation of dysphagia. Thankfully, it usually is not necessary. Most early postoperative dysphagia is due to edema and sometimes patient dietary factors. And with careful history taking, a little bit of watchful waiting, and patient coaching, it usually is not a persistent issue. However, if it persists beyond several weeks postoperatively, in the absence of other signs or symptoms, patients with dysphagia merit an esophagram. It's important to assess for recurrent hernia, assess the wrap. Is it overly tight? Does there appear to be a stenosis? And then this is often followed with endoscopy to further assess for recurrent hiatal hernia and evaluate the construction of the fundoplication. For patients who have dysphagia that continues to persist after dietary modification, radiographic evaluation, endoscopic evaluation, one might try dilation. Sometimes this is effective and sometimes not. But if it's not effective, then manometry really comes into the picture and plays a role. And so to illustrate this, here's another case study This is a very complicated patient who was referred in to us for kind of a second opinion for postoperative problems. She had a BMI of 38 with a history of celiac disease and a diagnosis of type 2 achalasia. She had initially presented to her physician for cough, heartburn, regurgitation, and dysphagia to tough solids. She'd undergone an endoscopy that demonstrated LA grade B esophagitis and a small hiatal hernia, an esophagram that showed some delayed clearance of the esophagus and a small hiatal hernia. Bravo off medication was performed, and this was consistent with pathologic reflux. She had a Demeester score of 29, so there was some debate about the diagnosis. Maybe fermentation was going on. And so then she underwent esophageal manometry. And we were able to obtain her images. This was pretty consistent with type 2 achalasia. She had an IRP of 26 with the absence of normal peristalsis. You can see some pan pressurization of the esophagus there. And she had a trial of Botox injection with her gastroenterologist, had some symptomatic improvement of this, and then went on to undergo Heller myotomy with repair of her type 1 hiatal hernia, with anterior and posterior cruroplasty and a toupee fundoplication that was performed over a 48 French bougie for this diagnosis of type 2 achalasia. Immediately postoperatively, her reflux symptoms improved, but unfortunately on a dietary advancement at 2 weeks, she had pretty significant solids dysphagia. Her diet had been backed down. She did an additional week of liquids, tried readvancement, and this didn't work. Had another kind of period of dietary modification backing things down. And at 6 weeks was still having pretty significant solids dysphagia, although she reported no problems with liquid. At this point, she underwent an esophagram. The esophagus seemed to be pretty normal in caliber. There was no overt area of filling defect or stricture. And the GE junction seemed to be appropriately placed. There was no evidence of recurrent hiatal hernia. She underwent a trial of dilation, and then I saw her and performed an endoscopy. And initially, I felt like things were pretty appropriate. So in the pictures on the left there, my scope is parked right above her Z-line, kind of within the fundoplication there, looking down into the stomach, and things seem very wide open. But then pulling the scope back into the distal esophagus, there was this area here where there was almost kind of like a little shelf. The arrow is pointing to what I thought was her anterior cruroplasty. And then you kind of see this sort of scope wants to drive into the distal esophagus rather than the lumen endoscopically. I didn't really know what to make of this though. Maneuvering the scope, I was able to go through the lumen of the GE junction just fine. Went into the stomach, retroflexed. The wrap appeared to be intact, no evidence of recurrence. It was nice and loose to traverse. It seemed appropriately constructed. I did an additional dilation, and she had no improvement with this. And so we obtained manometry. And a few things here of note. So her IRP had normalized to 8.8. She's regained a little bit of peristalsis, but she has incomplete bolus clearance of her distal esophagus. And she has two high pressure zones, one right at the diaphragm and one at the level of the fundoplication. And so my differential at this point was as follows. Could she have an incomplete myotomy? Well, I didn't think so. Her IRP had normalized. Could she have a recurrent hiatal hernia? The endoscopy and the esophagram did not suggest this. Was the fundoplication too tight? It had been constructed over a bougie. It was nice and loose to traverse. It appeared to be appropriately constructed endoscopically. What about her cruroplasty? Could that have been too tight? Well, she had this high pressure zone in her distal esophagus. She had this kind of endoscopic appearance of sort of a shelf, which correlated with where she felt the food sticking. And notably on her manometry, she had incomplete bolus clearance of her distal esophagus. So I discussed her with some of my colleagues, and she and I had a long discussion, and ultimately we elected to take her back to surgery. As anticipated, the myotomy was pretty densely adherent to the undersurface of the liver. But my surgical intent was to release the anterior cruroplasty, and we were able to approach the anterior hiatus from the base of the left crus and kind of go up around the liver. And I was fortunately able to identify her anterior crural sutures and release these. She, thankfully, both for her and for me, post-operatively, experienced relief of her dysphagia and was able to tolerate liquids and progress to a solid diet without difficulty. So manometry really helpful here in working up post-operative dysphagia in this complicated patient. So in conclusion, post-surgical manometry is valuable, certainly assessing for esophageal dysmotility prior to any reoperative fundoplication, but also sometimes in the post-operative period. So really post-op, post-fundoplication, and following bariatric surgery if a patient experiences dysphagia. It's important to swallow your pride and remember it's not always patient factors that are the contributing etiology. You have to go back to the beginning, check everything that you did, and make sure things are appropriate. So with that, I'd like to thank SAGES for the opportunity to present. I hope everyone is well out there and has a peaceful fall. Here's my socially distant hike in Utah the other weekend, and I hope you're finding some solace where you are. I hope I will see you at SAGES next year. Thanks.